So guys, this is the season 3 of the Mumbai Pain School Pain Journal Club, and we are going to start soon. This is the journal club in which we are going to discuss a very important topic. The theme this time is regenerative procedures for the spine, and I'll just start speaking now. Just a minute. So I hope you all can see my screen now. Just type yes in the chat box, or if you are viewing us on Facebook, just type yes if you can see the screen. We're going to start with the presentation. So today we're going to discuss facet and sacroiliac joint regenerative procedures. So last time we had covered the paper on facet instead of the caudal epidural one. So this time we are going to make up and do the caudal epidural in this journal club. So I will just start with the introduction. Okay, thank you, Dr. Kritika and Dr. Viren. So pain medicine world over is having diverse issues, variable standards, different learning requirements, and different offerings. So there is a lot of variation across the world. And money and time, the two things which prevent the pain physicians from understanding and learning and progressing in this respective field. To overcome this, Mumbai Pain School has been formed as an initiative by Penmetcha Spine Wellness and Pain Relief Center, wherein we are going to give the online education. And this we are using the social media, we're using the Facebook, Instagram, Twitter. We are mainly focusing on online learning and on-demand training. We have both free and paid content. We are having hands-on workshops as well. And we are fortunate to have expert faculties from all over the world. It's said that the best teachers, they teach from the heart and not from the book. A journal club is nothing, it's just a club. The only difference is that here we combine together our efforts to critically evaluate the recent academic literature, which is based on a defined subject. Attendee participation is the most important, so I request all of you to participate. So those of you who want to be unmuted, those of you who want to share your videos, put your video on, you're most welcome. Just tell me and I will do that for you. Your questions are most welcome. It's very tough to be regular, but you have to be regular. Even Harrison used to hold his journal club twice in a month. So the purpose was critical evaluation of the academic literature. So time and discipline is important. So I request the speakers to stick to their timelines. If your slide is too busy, try to make it interesting for the listeners. Healthy skepticism or praise is most welcome. And we want to put out all the points which will help us to evaluate the literature. So this is a bit about me, but today we have with us some reputed faculties. Dr. Taruna Penmetcha. She's MD and Division Chair in Acute Pain and Associate Program Director, Fellowship, Pain Fellowship, Department of Anesthesiology and Pain Management at the J.H. Stroger Junior Hospital of Cook County in Chicago, Illinois. In addition, she is also an adjunct associate professor in the Department of Anesthesiology at the Rush Medical College. She's also a member of various hospital-wide committees, and she's got multiple publications in peer-reviewed journals, and she's got recognized for the service rendered to the Pain Fellowship and patients. And also she's won the Attending of the Year award as well. So we welcome you, Dr. Taruna. Just let me check if she's there. Yes, she's there. So just let me make you co-host. You can say hi to all of us. Yes. Yes, so I made you the co-host now. So okay, we'll move ahead. I think he is joining. Okay, so we have Dr. Uttam Sidhaye with us, and he's a senior consultant in pain medicine at the Deenanath Mangeshkar Hospital in Pune. He's also the fellowship coordinator and honorary consultant in Bharati Vidyapeeth Medical College and Hospital, Pune. He is external examiner for various fellowship examinations and is also the invited faculty in pain conferences across the globe. So welcome you, sir. Now we will go on to the first presentation for today. So I request Dr. Jeshnu to please start sharing. I will just introduce you. Dr. Jeshnu, can you share your presentation?
Sure. Just a second.
Yes, you can share your presentation. Meanwhile, for those of you, yes, I can see your presentation. Can you put up your screen? I will just
okay, like
the next one.
Okay, the CV is not there, sir. Like you know me, it's long.
I know you, so I'll introduce you. So Dr. Jeshnu Tople is very well qualified. He's got DA, DNB, FIPM, FIAPM, FIPP, and also EDPM. He's the interventional pain consultant and works in various setups in Wardha and Nagpur in Maharashtra region of India. Over to you, Dr. Jeshnu.
Thank you for the nice introduction, sir. And thanks to the faculty also for joining us and giving your valuable time to us. So the title for today's journal was use of ultrasound guided platelet rich plasma injection of the sacroiliac joint as a treatment for chronic low back pain. It's a case report published in July-August 2020, and authors were Devin Broadhead, Italy. So to start with, musculoskeletal condition, as we all know, are among the top reasons for medical disability, and this also stands true for those who retire from the Army and Marine Corps. So back pain is one of the most common reasons why active duty military personnel seek the medical care during their tenure. Of those military members with certain occupations like motor vehicle operators are more prone for developing low back pain than the other service members and other occupations. Up to about 75% of the duty pilots also experience low back pain during their career. Of those, like we all know about the prevalence of low back pain, and it's about 15 to 30% of the general population. And the typical treatment includes the conservative management, which includes non-steroidal anti-inflammatory drugs and physical therapy and corticosteroids injection. However, there is relatively little information available regarding the treatment with regenerative therapy like platelet-rich plasma for SI joint dysfunction. So this case scenario was a patient who had SI joint induced low back pain with functional disability, which was drastically decreased through utilization of ultrasound guided PRP injection. Coming to case report, the authors encountered this 62-year-old female with long-standing right inferior pole SI joint pain. Previously, she had moderate but temporary pain relief with various treatments, which included all conservative treatments like physical therapy, manual therapy techniques, including chiropractic and osteopathy. Acupuncture was also tried. An intervention with fluoroscopic guided intra-articular corticosteroid injection was done. Also, epidural steroid injection was done. Home-based exercises, stents was also done. Local application of ice at the pain site of SI joint was also done. However, all these treatments were giving only temporary relief, and pain was coming back again and again. Even when the authors encountered this patient, diagnostic imagings were already done. It was suggestive of spondylosis of SI joint arthritis. Among these diagnostic imaging, X-ray with flexion and extension and non-contrast MRI of lumbar spine was done. Also, the inflammatory sacroiliitis was ruled out initially. A patient had pain with NRS of 5/10 and which used to increase up to 9/10 on prolonged sitting.
So, have they provided any of these images?
No, sir.
Okay, thank you. Please continue.
Yeah. On examination, authors found the patient had 14 finger test positive, Faber test positive, and Genselin test positive. However, the provocative test for other pain generators of low back were negative. So coming to the previous treatment was this, what this patient was receiving. She was receiving 390 morphine milligram equivalent, which was in the form of 30 mg of methadone and morphine sulfate immediate release. Initial treatment also included ultrasound guided injection of right SI joint ligament utilizing combination of triamcinolone 40 mg and 5 ml of lidocaine 1% and bupivacaine 0.25%. However, over the course of 5 months, pain was reduced to 3/10 with the use of corticosteroids, and attempts were made to win the patient from opioid during this period. At 6-month follow-up, the patient reported with return of pain and deterioration of function. So at this point, authors thought of PRP injection, which was injected both into the ligament and posterior aspect of joint capsule. So how it was done, authors prepared autologous PRP using Terumo BCT Smart PREP 3 platelet concentrate system according to the manufacturer's instructions and guidelines. For that, 60 ml of whole venous blood from the patient's arm with 19 gauge 3/4 inch needle was used, and it was mixed with 8 ml of anticoagulant, which was ACDA. It was centrifuged for 15 minutes at RPM of 3200. Then the platelet deficient portion was extracted and discarded, while the platelet-rich layer with buffy coat to include white blood cells and red blood cells was remixed, and this resulted in approximately about 5 ml of PRP. Then, with the use of curve probe in conjunction with 14 finger test, the point for site of injection was identified. Utilizing ultrasound guidance with 3 inch of 22 gauge spinal needle was inserted in medial to lateral fashion with in-plane visualization. Of that, 3 ml of concentrated PRP was injected into the SI joint and adjacent soft tissue, including the posterior sacroiliac ligament and joint capsule, as the needle was withdrawn. The patient was then monitored for about 15 minutes post-injection for acute complication, and nothing was observed. The patient's pain was recorded using NRS, and functionality was using the Oswestry Disability Index at the time points of 2 weeks, 4 weeks, 6 months, 9 months, and 1 year after the injection. The percentage of change in patient's NRS and OAS scores were compared from baseline to the all follow-up time points. So coming to the results, this is how the results were plotted on the graph. On pre-injection, patient had NRS of 8, which increased to around 9 during for the first 2 weeks, and then gradually decreased over next 1 year. And this was about the ODI scores again, which was increased after 2 weeks, but then gradually decreased till 3 months, and then it was around 50% to 40% for the next 6 months. So this is again the same thing which was which is given in tabular form. During this follow-up time points, opioid was winning of the opioid was started after 3 months of the procedure, and at the 6 month of follow-up, patient required around 80 mg of morphine equivalent, and also reported improvement in the function. About 9 months of follow-up, the patient was completely weaned from the opioids. At 1 year of follow-up, the patient also maintained the opioid independence, which was the last time point for follow-up time point. So coming to the discussion of this case, PRP has been shown successfully in treating chronic low back pain originating from musculoskeletal origins like tendons, ligaments, and muscles, as well as joints like shoulder, knee, and SI joints, and intervertebral disc. However, the literature available for use of PRP for SI joint is very minimal. There was one prospective trial done by Singla et al., which was published, who investigated PRP versus corticosteroid injections for low back pain relief secondary to SI joint dysfunction. And in that, they found that PRP significantly decreased the VAS at 6 months and 3 months compared to corticosteroids. However, there was no significant difference at 2 months and 4 weeks. At 2 weeks and 4 weeks, this The prospective trial suggested that PRP has the most impact starting at about 1.5 to 2 months post-injection and has more long-term effect. Even if the corticosteroid injection does provide temporary reduction of NRS, it comes at the expense of decreasing the body's ability to heal itself at the site of injection. And as compared to the other treatment of this case, PRP injection demonstrated to be superior for longer duration of effect. The greatest reduction from the baseline in ODI occurred at 3-month mark, while the greatest reduction in NRS occurred at 9 months of follow-up and continued up to the 1 year. This interval has showed the largest reduction in ODI occurred between 1 to 3 months, while the greatest reduction in NRS was between 6 to 9 months. The patient had continued to experience tenderness in the right lumbosacral area, and Gansner's test as well as fever test remained positive during on the right side during follow-up. Also, with respect to opioids, opioid-induced hyperalgesia produces a diffuse ill-defined pain that extends to the area apart from location of the pre-existing pain. Look at the history of this patient. This patient was taking large doses of opioid equivalents, and this can lead to opioid-induced hyperalgesia also. That's why the discussion of opioid-induced hyperalgesia is very necessary for this case. And as the patient's pain remained localized to SI joint throughout the case, authors thought that OIH was ruled out. Despite the longer duration of onset, the significant reduction of pain and disability coupled with sustainability of the result makes this PRP intervention promising for active duty service members without significantly impacting the workflow within the individual's duty sections. Limitations accepted for this case report by authors where further investigation is needed to compare the risk, benefit, and usefulness of the treatment of SI joint induced low back pain with ultrasound guided PRP injection for in larger sample size. Also, they accepted that patient did not receive any repeat imaging during the follow-up period. Coming to the critical analysis, as we all know, case report does not have strong level of evidence, so we need lot of large multi-centric randomized trials to prove that PRP is really helpful in comparison with other treatments. Also, we all know that there is no standardization about the preparation, doses, and frequency of platelet-rich plasma. In this case, I feel that there is chance of bias as the observation for the NRS and ODI during follow-up time points where the observer was not blinded. And also there was no discussion about radiofrequency ablation or cryoablation, which are established treatments for SI joint. So take home message from this is ultrasound guided PRP injection of SI joint can potentially reduce to decrease pain, improve functionality, reduce the prevalence of chronic low back pain, reduce medical disability retirement. It can reduce the opioid use disorders in military. It can also lead to earlier return to the active duties, and it can reduce delays in recovery. Thank you so much.
Thank you, Dr. Jeshnu. I think based on the exhaustive presentation, some of the slides were really busy, but I think those are certain kinds of input. But still, we can hear it's a good presentation. Over to you, Dr. Taruna. Would you like to ask some questions? So we cannot hear you, ma'am. Okay, just wait. I'll just make you co-host. Can you unmute yourself now?
Okay. Good morning. Good evening, actually. I'm sorry I wasn't able to unmute myself earlier.
Yes.
Good morning, everybody. So this is a case report, so it's a little bit hard to make any judgment based on a single case report. But definitely, there is a role of PRP based on the other joint injections. So there was this paper that was cited where from 2017 from Singla et al., and that had SI joint injections done with PRP, which showed significant benefit. So I think a lot more studies are required at this time. There was no mention. It is hard to understand, they did a ligament injection and not an SI joint injection with steroids prior to the PRP. Is that correct? Did they say what was the difference between the steroid injection that was done in this patient and the PRP? Because looks like the PRP was done in the joint, but then the steroid injection they are describing is in the ligament. Is that the understanding?
Yes, ma'am. They haven't discussed about how the steroid injection was done.
Okay. Okay. I don't have any questions regarding this case. I just feel that based on one case report, it is hard to say whether the patient had significant response. And SIJ joint pain by itself, in a lot of patients with chronic low back pain, it is very hard to differentiate if the patient only has SI joint pain or it is coming from multitude of other degenerative problems in the spine. So I would like to see the imaging and whether there was a follow-up done afterwards, if they did further imaging, if they figured out it was just SI joint pain or there were other issues with this patient. And 1 year follow-up, although it's a decent amount of time, but long-term follow-up for this patient who apparently stopped all the agents and all the opioids that he was using, 390 milligrams of 390 MMEs of morphine. It would be nice to see what happened to this patient later on.
Yeah, great. Because just with one injection, it's it's kind of a very I think dreamy result. I mean, I would like to have this kind of result. So I think it's a great paper, but I think we can maybe have some more evidence. Dr. Uttam, you like to say something?
Yeah, Jeshnu, did they mention about injecting the PRP along with the local anesthetic, or they just injected the PRP?
There was no mention about local anesthetics, so that's why there are like lot of flaws I could find. They haven't provided any imaging. They haven't discussed about the previous corticosteroid techniques. Like Dr. Sidharth right now said, single PRP injection giving long-term benefit. In our clinical practice, we see that we usually need multiple PRP injections. So
and what about the PRP? Those leukocyte-rich PRP or leukocyte?
It was leukocyte-rich PRP. Actually, they haven't mentioned specifically, but then they WBC and bit of RBCs together. So I hope it is leukocyte-rich.
Great. So I think let's move on to the next presentation. There are no questions from the participants who are listening. Guys, please type in your questions in together. Meanwhile, let's go on to the next presenter. Dr. Maitri, I have made you the co-host. So you can start.
It's a problem on my side. There is a lot of echo.
Yeah, I'm having the same thing. It's hard to hear.
Yeah, I think I'll just shut. Okay, now you don't have the echo, right?
Yeah.
So I think this is sorted. Dr. Maitri, can you start with your presentation? Can I help you? Okay. Yes. Please make it full screen and put on your CV slide so that I can introduce you. Yes. So Dr. Maitri Shah is done her MBBS, DA, FIAPM, and then now she is working as a spine and pain physician at ACME Hospital in Mumbai. So over to you, Dr. Maitri.
Good evening, everybody. My topic for today is a randomized double blind control pilot study comparing the leukocyte-rich platelet-rich plasma and the corticosteroid in caudal epidural injection for complex chronic degenerative spinal pain. It is a prospective randomized controlled double-blinded study. It was published in World Institute of Pain 2020. The authors of are Ricardo Ruiz Lopez et al. The studies performed at Clínica Vertebra Spain, Barcelona, at the University of Barcelona, Spain, and the Department of Anesthesiology and Center of Pain Management, Taiwan. Introduction. So, epidural corticosteroid injections have become a standard part of multimodal pain management algorithm for the treatment of lower back pain, whether as a result of chronic spinal deformities or conditions associated with acute radicular pain and chronic degenerative spine pain. Despite the wide use of epidural corticosteroid injections as a modality for chronic degenerative spinal pain, its effective remains controversial. PRP injections have gained considerable attention as a treatment modality for musculoskeletal conditions such as tendinopathies, muscle strain injuries, ligamental tears, and osteoarthritis. PRP is a biological blood-derived product with platelet concentration 3 to 5 times higher than the physiological baseline. Hence, PRP has a potential to enhance body's natural healing process through various actions or its related growth factors. Continuing, the aims and objective of the study are aimed to compare the efficacy and safety of leukocyte-rich PRP against the long-acting depot corticosteroids by caudal route for chronic degenerative spine pain of non-malignant origin in which conservative therapies have failed or primary invasive therapies are not indicated. Secondly, to compare the efficacy and safety between similarly. Third, the methods. 50 eligible patients with complex chronic degenerative spinal pain were randomly assigned with 1:1 allocation ratio to receive caudal epidural injections of the corticosteroid Triamcinolone 60 mg or leukocyte-rich PRPs with 60 ml of prepared from 60 ml of autologous blood under fluoroscopic guidance. Levels of low back pain, quality of life, and complications or adverse effects were evaluated at 1, 3, and 6 months after the treatment. Pain levels and quality of life were assessed using VAS, Visual Analog Score, and short form 36-item health survey, SF36 respectively. The study was approved by the Ethics Committee of Hospital HM Delfos, Barcelona, Spain, and conducted by the principals of the Declaration of Helsinki at Clínica Vertebra, Barcelona, Spain, and Pain Surgery Center, Barcelona, Spain. Inclusion criteria. Consecutive patients with well-established complex degenerative lumbar spinal conditions who were diagnosed through MRI or neurophysiological studies were eligible to enroll in this study. The lumbar pain was radiating or not radiating to the buttocks and groin and should have at least lasted for more than 3 months. The exclusion criteria is diabetes mellitus, history of ongoing malignant disorders, autoimmune diseases, active infection of the area to be injected, hematological disorders, use of antiplatelet and NSAIDs for 3 days before the procedure, pregnancy, use of epidural or systemic corticosteroids within 3 weeks before the treatment, mild or severe anemia, platelet count less than 150,000, and any indication of imperative open spine surgery. Continuing, just explaining the procedure of how it was done. An autologous 60 ml blood was collected from the basilic or cephalic vein of each patient upper limb, and 5 ml of acid citrate dextrose was added to the blood sample as an anticoagulant. The blood mixture was centrifuged for 14 minutes at 1568 God, resulting in 3 layers: a lower layer composed of red blood cells, an intermediate layer composed of white blood cells, and the upper layer composed of the plasma. The intermediate and the upper layer were collected and were ready for injection after quantification using the laboratory analyzer. Local anesthetic agents were not added to the preparation, as anesthetic could affect the platelet activation through altering the pH of the solution. The patient was placed in prone recumbent position and maintained in slight sedation by intravenous administration of midazolam. The skin at the dorsal sacral area was carefully prepared and draped. An 18-gauge 2E epidural needle was accessed to the S3 L4 epidural space under fluoroscopic guidance. The correct placement of needle was verified by injecting 2 ml of non-ionic isoxazole contrast medium in the patients assigned to the PRP group. A total of 20 ml of PRP mixture, that is 16.5 ml of leukocyte-rich PRP and 3.5 ml of non-ionic ioxol contrast medium was injected through the Tuhi's 18-gauge needle. The spread of the solution along the epidural space was closely monitored under fluoroscopy with AP and lateral views throughout the course of administration. In the corticosteroid group, patient received epidural injections of 20 ml corticosteroid mixture, which was 60 ml of transilon acetonide and 3.5 ml of ioxol contrast medium in normal saline. Post-procedure, all patients were transferred from the operating room to the recovery area in the recommended supine position. Patients were discharged home after 90 minutes later, provided no acute complications or secondary effects were observed. Patients were instructed to rest for at least 24 to 48 hours after the caudal epidural injection and encouraged to drink sufficient amount of water. And oral analgesic, that is paracetamol 1 gram, every 8th hourly was prescribed for pain management for first 48 to 72 hours. Patients were instructed to avoid NSAIDs, corticosteroids, or any other analgesics or medication that might affect the platelet functions. The study protocol did not have any limitations on patients' daily activities after the discharge from the hospital. All patients were contacted via telephone interview within 24 hours after the procedure by an experienced nurse for any procedure-related adverse reactions. Patients arranged to return to the outpatient clinic at first, third, and sixth month after the treatment, and a visiting medical doctor assessed the patient on basis of the visual analog score, current analgesic medication, and activity of daily living. Patients were also asked to complete the SF36 questionnaire at 6 months after the treatment. A medical doctor who assessed the post-treatment VAS and SF6 questionnaire was unaware of the treatment groups. Results and discussions. So first, the discussion. So here, the age and the sex of either of the groups, that is the corticosteroid group and the leukocyte group, were the same. So there was no difference there. And the visual analog score of the corticosteroid group and PRP, the thing is, with the corticosteroid group, there was a major change in the score at the first month, as shown here. But at 3 and 6 months, the PRP group had better results from the baseline. This is the chart showing the same. The score was quite deeper at the first month, but at 3 months and 6 months, PRP showed better results. Also, on the 6-month analysis of the whole thing, the bodily pain remained similar in both the groups, but PRP showed better results or better improvement in all the scores compared to the corticosteroid groups. Continuing, there were no complications or adverse effects related to treatment at 6 months of the follow-up for either group. Only one male patient in the leukocyte-rich platelet PRP group experienced itching in the pelvic area, which was progressively elevated after treatment with dinephridine. It's an anti-allergic. In this randomized control trial, caudal epidural leukocyte-rich PRP injections guided by fluoroscopy led to a significant reduction in pain score and improvement of life quality in patients with degenerative spinal pain when compared to the either pre-treatment values or those in the corticosteroid groups, as we have seen earlier. Multiple advantages have compared to the transforaminal and interlaminar approach, including more effect of targeting to the lower lumbar sacral area and more spreading of the inject to the ventrolateral epidural space. Ideal interventional or biologic therapy for degenerative spinal pain should elevate pain and slow or reverse the catabolic metabolism within the spinal structures. Numerous formulations and technique for PRP production exist, and various approved commercial PRP preparation kits are available, but with no universal PRP end products. Individual patient factors such as age and comorbidities can cause difference in PRP related growth factors and overall composition. The use of leukocyte-rich PRP may produce more intense local inflammatory changes. Reported that leukocytes in PRP have positive anti-infectious, immunoregulatory, and antiogenic effects. Epidural leukocyte-rich PRP injections offer the possibility of inhibiting the degenerative changes and may provide a better treatment alternative in future. Further on, the result of this study suggested that the progressive healing could have played a significant role in clinical improvement of the leukocyte-rich PRP group, as the analgesic effect and quality of life improvement in leukocyte-rich PRP injections were predominantly found in later stages of the follow-up period. In comparison, the corticosteroid group only showed short-term clinical improvement, which was then followed by decline at the first month follow-up. Autologous leukocyte-rich PRP may be better injectable biological alternative than corticosteroid in treatment of degenerative spinal chronic pain of complex origin. Limitations accepted in this study are the study was limited at relatively short follow-up period of 6 months and lack of placebo control group. Long-term study might have needed and observed the effects of leukocyte-rich PRP. The study did not compare the efficacy of epidural PRPs with different leukocyte concentrations. Critical analysis, high quality of randomized controlled trials on caudal epidural PRP injection in treating degenerative spinal pain is missing. Very small sample size, that is just 50 patients. Primary, secondary objectives were not defined, and drawbacks of epidural injections or side effects or no relief are not discussed in detail. Take home message, both autologous leukocyte-rich PRP and corticosteroids for caudal epidural injections under fluoroscopic guidance are equally safe and therapeutically effective in patients with complex chronic spinal pain. However, leukocyte-rich PRP is superior to corticosteroids for a longer pain-relieving effect and improvement in quality of life. Hello.
Thank you. Yes. Over to Dr. Uttam sir. Sir, would like to ask some questions or comments?
No, I'm just unable to understand because the role of the corticosteroid is different than role of the PR platelet is different. Because
Yes.
corticosteroid we are giving for the anti-inflammatory effect and leukocyte-rich platelets we are creating inflammatory effect in the. So I'm just unable to understand why they have compared with the two this thing.
For pain, Matthew, you can take it.
No, sir, go ahead. Sorry.
So I think, sir, they want to just see which one works better, just like we use the same for the two indications. So I think that is what they want to make out. I don't know whether I've understood your question correctly or not.
So they are just trying to, maybe they are just trying to use the different method to relieve the pain.
Yes.
The main idea was to compare it with the corticosteroid, because the corticosteroid is usually used since a long time, but again the shorter relief and the use of corticosteroid and the side effects because of it. So they wanted something which is more effective for the patients on the longer term. So that was the idea, but again not very clearly mentioned with why over the corticosteroid.
Do you have any papers regarding the transforaminal approach for the injecting the platelets? Any research paper you found during your
We have presented one in the last journal club.
Last previous journal.
So I do have, I think with the corticosteroids, like Dr. Sindhye said, that we are using corticosteroids because of the anti-inflammatory effects, but with PRP in particularly, I think your question is why leukocyte rich, because those are inflammatory. So why are we putting that instead of the corticosteroid? So I think it is the platelet rich component plus the leukocyte rich, both of them is going to give some significant long-term relief because it causes regeneration. That's what the thought is. But my thought with this paper was, although it is well designed, there is a small sample size of 50. I'm not sure, are there other papers with epidural use of PRP? I did look, but there were not a lot that I could find. So maybe this is a pilot where they are doing it with caudal approach, so 50 is a decent sample size. The paper is well described, and the study was double-blind, randomized control, so it was done well. The only thing was the patients that were selected, it was radicular pain, non-radicular pain, patients with different components, maybe facet, maybe disc problem. So it was not very clear, what was the etiology of pain in these patients that were selected. So it was, plus the selection criteria was either MRI or neurophysiological studies. So it is a little bit vague what was the patient population that was selected for this study. The other thing was, there was no mention of what the patient's medications was, analgesic medications, pre the treatment and post-treatment. Was there a decrease in the analgesic use? That wasn't mentioned in the study. So I'm not sure if these patients were on opioids, non-opioid analgesics. Did they continue it after the PRP injection versus, did they decrease it after the PRP injection? That was not clarified on the study. So that would definitely help to know if it did cause a significant benefit in terms of pain score, in terms of functional scores. That would be good to know. The study was done for 6 months, so I think long-term follow-up is definitely required to see if there were any long-term complications. The volume of injectate was almost 20 ml in PRP, and in both the groups, give or take, it was around 20 ml. So were there any long-term issues like arachnoiditis, anything that was there that would require long-term follow-up on these patients? Dr. Verma.
Yeah, I think these are very well, critically analyzed by you, ma'am. So I think this is extremely an early paper in this field, and that's what we wanted to highlight. That maybe we can learn from the shortcomings of this paper, and some of us can maybe in future do something which is better. But of course, PRP is having a twin effect, and as you rightly mentioned, that if we are using a leukocyte rich PRP, we are more focused on drawing the inflammatory response there so that the regeneration can happen. And in this case, if it would have been probably more logical to get a poor one, maybe. But as we see, there's a lot of ambiguity in the literature as well. And as we saw in the last papers, in most of these papers, I have chosen after probably we have discussed, and then I have chosen after quite a great difficulty, because very, very few papers are there on this subject. But nonetheless, we understand that these are the limitations, and probably they should be taken with a pinch of salt, and not immediately all of us should start. Okay, it doesn't mean that tomorrow everybody should replace their caudal epidural steroid with the PRP. Certainly, that's not the message. So I think Dr. Uttam, will you like to add something?
So, see, I don't have any experience about injecting PRP in the caudal space, but this will be very interesting to see how this help in the outcome of the patient. So the way we are doing giving in the joints, we have in the tendinopathies, we have good follow-up for the patient, and we are routinely giving nowadays for these conditions. For caudal epidural, I don't have any experience about it, but interesting to see this paper like this of injecting the PRP in this caudal space.
Great. I think we take some questions from the attendees now. Doctor, this is more of a comment. Dr. Viren is saying steroids we use for inflammatory cause of pain, and PRP mostly for degenerative causes. So that's also correct. And however, the problem here is that many times there is a combination of both of these changes. So maybe you may have degeneration and then secondary inflammation, which may be secondary to it. And probably that's the reason. And in fact, if you see, many of the authors have combined in the same patient, they have first used the steroid, then given a small interval to reduce the inflammation, and then use the PRP also. And that also has been used. In fact, I was surprised to see that some people have even combined both together. So that's a counterintuitive, but papers are papers are there for that as well. However, I am quite skeptical about this combined approach, but definitely, if used some period apart, I've recently tried in a patient with the with the decurrence tenosynovitis. She had a big effusion, and I've tried with the steroid first, and then her effusion was reduced for some days, and then we, after about 4 weeks, we had called her and assessed. The effusion was really reduced, and after 2 more weeks, probably we are now planning PRP for long-term relief. So that those things can be, of course, tried, but definitely it's still lot needs to be researched on that. So I think this answers your comment, Dr. Viren. Dr. Mohammed is asking, okay, this is not related to this particular paper, but may be related to the technique. He's asking what is more effective, caudal, selective nerve root, and interlaminar. So I think that's in short, it depends on the pathology and of course what you want to achieve. And all of them are effective in the respective pathologies where, so we will skip this actually.
Just to follow up on that question, it's asking the forum, how much volume do you put when you do single shot caudal epidurals?
So yes, so single shot caudal epidurals, what I will probably do is I will just put in a dye first, and I will wait for the spread of dye to reach the intended levels. This is what I do, and usually it is around 15 ml or 20 ml. That's the way I do it. And Dr. Uttam, can you comment something?
Yeah, I put max 8 to 10 ml in this thing. If I want to go a little upward, then I put the catheter.
Yes.
To the caudal, and then I inject the drug.
Yes. So
looking at the dye, how
since I have actually, I changed my practice from caudals to more. I would rather do 2 or 3 transdermals nowadays rather than going in from caudal and then trying to reach. Unless there is a lot of adhesions, and I then I want to kind of bathe all the cauda in the drug. So I have reduced caudal epidural in my practice.
We are still doing it. I mean, for patients who have extremely tight stenosis and they are doing okay with the epidural. Sometimes certain patients, older population does not want any further interventions or surgery. Those patients we sometimes do caudal, but and the other group is failed back or laminectomy patients where you don't want to go into laminar. So those are the only patient groups that we are probably using caudal still as an approach.
Yes. So in my case, I am now shifting to PSLD. So that is we are doing the resection of the ligamentum flavum in the older group. So this is a very big lacuna which I had in my practice. I felt that I am unable to treat the patients for stenosis, and I think this was something which we have now overcome with the introduction of this technique. So I think more and more with the addition of these more and more techniques in our armamentarium, the things are going to get much exciting. So less role of this classical. I think this would have been the first procedure for many of us, or maybe at least some of us. So this is what it's in my side, from my side.
Sure.
So next question is from Dr. Naima. How about doing these procedures under MSK USG only caudal epidural? So yeah, of course, that I mean I could not find any papers, but that's of course it's possible. Only thing is you can't see the spread. Like what I was mentioning is that when I would do it, I would see the spread with I just give a dye, then a little bit of drug, and then maybe a little bit of more dye, and then the drug. So in this way, or maybe I can mix both and then see the spread of the injectate live. and not in a continuous, but I will just take a shoot and then after some time take another one. And this will help me to reach my intended levels and of course, like Dr. Uttam said, we can put in the catheter and try to achieve the same effect. I routinely do this for the cervical levels, so no reason we cannot do it for this level as well. But definitely you can use it for the entry. It's not a problem, Dr. Naima. So I think this answers the
First
question.
of all, I will share that image with you, Sidharth.
Yes,
Yesterday I did one caudal epidural, and I can show the image how
yes, sir. I have seen that image. The
so
Bateson plexus. I think that's a best image of the plexus without dissection. I think.
so I I'm scared of doing completely under ultrasound. So whenever I will do that caudal, if I want to do, I will definitely do a combined technique if that's all I want to do.
So, do you have the picture, sir, right now? No.
Right now,
Let me just try and get it.
yeah, I will try to.
I think quickly I can just share that. Maybe I can get it from the, because this was a very important lesson, and if we can just see this image, just make it okay. Yeah, I got it, so I can just share it. And guys, this is a because it's caudal epidural and somebody asked about this thing, so you can see. Dr. Uttam, you want to explain the image?
So what happened? I was doing this caudal epidural for the patient, and unfortunately, I got a not 18 gauge needle, and a 16 gauge needle was available in the theater that time. So I said, okay, I will do with the 16 gauge this caudal epidural, and I injected this thing, and I thought it's in the epidural space, and I injected a dye, and I got this picture. So after that, I scared that thing, and then I waited for. Then I called for the 16 gauge epidural full set of 16 gauge catheter. I was able to that this track was formed with the 16 gauge needle. So it was very difficult for me to form the second track with the 18 gauge needle, but I was able to do it and I completed the procedure. But this was very scary. After that, I decided I will not do it under. If purely somebody is doing under ultrasound, so they should avoid that thing and they should use the combined technique for the for at least for the caudal epidural or any spine procedures. They should use the combined technique, ultrasound as well as the fluoroscope.
Yeah, I think that is what we have been recommending for quite a long time now, that
Right.
whenever you're using it in the central structures, it's always better to use the fluoro, at least take a shoot.
Okay.
Okay, so there are no more questions. If there are any more comments from Dr. Uttam, Dr. Taruna, Dr. Maitri, we can take them now. Or if anyone wants to say anything, just type in quickly, guys, so that we can end the session.
So I definitely would like to thank you, Dr. Verma, for continuing to do these journal clubs. These are excellent. And over time, since I've been attending, I see the way the presenters are doing. They're really into it. They're doing an excellent job of reviewing the paper and doing the presentation. So I really commend everybody, Maitri and Dr. Jeshnu. Thank you.
Thank you, Sidharth, for this excellent thing you are doing for the maybe it is not only for the fellows, it is good for the consultant also.
Definitely.
Thank you so much. So I think all credit to the presenters putting in so much of efforts. I really have to sometimes push the things to the level. In fact, I was wanting to continue every week, but then I thought it's not possible for most of us. So, but still, I'm happy that we have been able to continue this. So thank you for the wonderful discussion. This is the season 3 of the Pain Journal Club, and we are focusing on regenerative procedures for spine pain. And We have a new time, 8 p.m. We have grouped some topics. We have done 2 faculties, 2 papers. And of course, guys, the secret of getting things done is to act. So join our mailing list and contribute. If anybody wants to present the journal club, please let me know. In future journals, we can probably involve you. The WhatsApp group is in the chat or in the email. Just email me any suggestions, comments on mumbaipain@gmail.com. I'll personally review and get back to you. And of course, we meet the next Friday, 8 p.m. And those of you who are interested to attend our hands-on workshop, we have the next hands-on WIPC is on 4th and 5th of March. So please do consider attending. So thank you so much, all of you, once again, for joining in, especially the speakers, Dr. Maitri, Dr. Jeshnu, Dr. Uttam, and Dr. Taruna. So see you around very soon. Until the next week, have a good time. Bye.
Bye bye.
Thank you.
Thank you.